Hello, doctor. I hope all of you are doing fine. Um, congrats for all the doctors that who passed their exam in January patch, and I hope all the people in February patch also will have the same results. And for the people who didn't pass, well, hard luck. Most of you was unfortunate, so don't worry. Okay. If it's half mark or 1 mark, you're nearly there. Just do the hard work and for sure you'll pass. Okay, next time. I'm very happy. Our results, nearly 99% of my student or the doctor I was teaching, they pass. And really, one of them had 98.5. That's that's been particularly make me very proud. Yeah, and hopefully these doctors will join me soon after they finish their CCT to to expand the team and expand the teaching and accommodate all the requests for the mini mocks and one-to-one teaching. I know that March time is now fully booked. I will try to accommodate more doctors as much as I can. April time is nearly booked also. There is only um, one slot, I think, available in the evening or something like that. So I hope I will be able to, recruit some of the doctors to be with me to help me in the teaching. Okay. Today we will speak about very important topic. Okay, for the people who don't know me, I'm Dr. Salim, one of the GPs in East of England, in Kings Lynn. I have wide, vast experience in emergency medicine before becoming the GP nearly 14 or 15 years. I graduated since 2007, and then I make multiple studies. Okay, one of them is my master degree in emergency medicine, then finishing the MRCM and the 4CM, and then I had the cardiology diploma as well, and then lastly the RCGP. Okay, and finishing my CCT in the UK here, and I'm working now currently in Kingsland. So I'm trying to spread the knowledge and the help the doctors that struggling with the SCA exam or even the AKT. The YouTube channel, I think it make a fair support for the people, and I'm trying to expand the way that the teaching and modify the way of the teaching according your needs and according to the upcoming changes in the exam. And the aim is to make a better future, a better doctor in the future. Okay, and improve the quality of the primary care knowledge as much as I can. And at the end, to convey the knowledge that I gained during my years of experience in the emergency medicine to implement it in the GP land, um, hopefully. Yeah. So today we'll talk about scenarios where there's a difficult consultation or difficult conversation between you and the patient. We'll take one example. The rest are discussed in the video course. So if you want the access to these videos, just send me text and I will give you the access. Okay, the topics are breaking bad news, and we'll have a good consultation now about breaking bad news, and then how to discuss future care plan with dying patient or end of life care, as well as what is the plans for the dying patient and how to discuss with him what his expectation and wishes when the time come, and and where he wants to spend his last moment between either between in his house between their beloved one or in medical care facilities and what is the drawbacks and what is the cons of each situation, and then how to complete the respect form. Okay. And what is the difference between respect form and DNR CPR form. Okay, and then talking with angry patient and how to accommodate the anger and understand from where the patient is coming. Okay, so we'll hear to a case in which the doctor, the GP, did examine a patient having persistent headache or recurrent headache, I think with red flags, and then he decided to make for him a scan and blood test. And then after the scan and the blood test, it seems to be that there is a mass effect lesion in the brain, and how to break the bad news in layer form, and how to use the verbal or non-verbal communication skill in delivering such bad news. Okay, mostly we'll see now the verbal. Okay, rather than a non-verbal, so the facial expression will not be there because the video recording. But in our courses, we are teaching the doctors how to use the verbal and non-verbal communication to be able to conduct such bad news, or accommodate and convey the diagnosis to the patient in the least intrusive way. Okay, because bad news is bad news. Patient will be sad. That's without doubt, and that will have a negative impact on you during the day when you are having other consultation. Without doubt, for sure, because you are a human like any other human. You will be affected by bad news. Okay, even if it's not affecting you as a human physically, but it will affect you also emotionally. Okay, especially if you are having a long-term relationship between you and that patient. So let's just start and listen to the video. And again, as we use the last three sessions, there will be script, although I'm against that, because I don't like the script. Um, Let's open it and the traditional item.
Hi, good morning. I'm Dr.
morning,
Rich.
Doctor.
Can I just double check your name before we start, sir?
Scott, yes, Henry Scott.
Henry Scott.
Yes.
Okay. And can I just check your date of birth, Mr. Scott?
Yes, it's the 2nd of June 1994.
Okay, so that makes you 28, does it?
Yes.
Okay. And how would you like me to address you?
Whatever you like, I don't really mind. I would say it's okay. Henry's fine, people
Okay,
at work
Henry.
call me Henry, so...
Okay, fine. Well, call me James if you'd like.
Right.
Now, before we sort of start discussing things, is there anyone else with you today that you'd like to have in the room?
No. Why, I mean, is it... It's not bad news, is it?
Well, we've got a lot to discuss, and sometimes it can be hard to remember everything, and sometimes there's a family member that you
Okay.
might want.
No, the wife's not here, with the kids and things,
Okay,
So,
fine. Okay. Well, there's probably a lot of questions, but just for me, before we start, could I ask what your sort of understanding of things so far is?
Well, I seem to have had some sort of... I've been having headaches over, quite the past few weeks or so, and, I've been on painkillers and things, and going on, really, and I've had sort of various tests and things. I'm not quite sure what they're looking for, but scans and these sort of things, and the, blood tests and what have you. but I don't really know any results at all or what's happening.
Okay, so you've had some blood tests, some scans, and no one's really told you what the results are, or
No,
it sounds like
or
really what the
indeed
intention
really
is.
altogether what they're looking for, but well, there we are.
Okay. Well, I think what I'd like to do then, first obviously, is to tell you what the results of the tests are.
Yeah.
What this means in terms of a diagnosis for
Yes.
you. And then we'll move on to talking about how we're going to treat you. Which
Okay.
I think is
so
probably...
So you obviously found something wrong.
Yeah, we have. Now, what we have found is something that's maybe serious, and I think we do need to discuss in quite a bit of detail.
Oh.
So, are you happy to discuss these sort of things now?
Well, yeah. Oh, yes. I mean, you say so, maybe serious. I mean, obviously, I want to know what it is. I mean, when you say serious, I mean, how serious? Have I, you know, I mean, you've not found cancer or something, have you?
All sorts of causes. You've had lots of blood tests, all of which have been completely normal.
Right.
Now, you've mentioned cancer.
Yeah.
And that is one of the things that we always want to look for. It's
Right.
a rare diagnosis, but if it's there, it's very important, because if you find it early, you've got a much better chance of successfully treating it.
Right. Okay.
Now, you've had the scan of your head.
Yeah. Yes.
Now, what we can see on that is that there is an abnormality.
You mean when you say an abnormality, this is your medical jargon for cancer?
I think cancer is a possibility. We've got to be upfront and honest about that.
Oh heavens, it's bad as that. I mean, it seems very sudden. I mean, I've only had these headaches for a few weeks or so, and yes, I had this sort of collapse, but surely not. And it's in the brain, is it? I mean, that's even more serious, isn't it, than maybe in the lungs or something, a brain cancer. Surely that's the worst scenario.
It's absolutely an alarming thing to hear, and I can't disagree with that.
Right.
However, what we've got to think about is in terms of treatment and prognosis, and many growths or cancers in the brain are very treatable, especially in comparison to some cancers in the lungs, like you mentioned.
I mean, let me be clear. You're saying it might be a cancer, but at the moment you're not sure whether it's a cancer. Am I right?
I think it's very likely that it is, but what we need to do is get the experts to review the scans.
Right.
Because what we don't want to do is make any life-changing treatment decisions.
No.
Based on...
Till you're sure.
Yeah.
Yeah, I see that.
So what I'd like to do is think about your treatment in two terms, a short term,
right,
and a slightly longer term, where
okay,
everything's been reviewed by all of the specialists and we've got all the best opinions that we can get.
This is assuming that it is a cancer.
That is
when
assuming
you've confirmed
that
it. This is what you would be doing. If it's not, then you'll be doing something else. Okay, let me start being clear, because I'll have to explain this to the wife and everything. So let's try and get it clear in my own mind. Okay.
Okay.
Yeah.
So in the short term, you mentioned that you've been having headaches.
Yes.
And that obviously one of the reasons that these may have been happening is that when there is a growth in the brain, it can cause a little bit of inflammation and swelling around it. So what we would do in the very first instance is give you some medicines that we would call steroids, which will help reduce that swelling and hopefully reduce your headaches.
Right. But that is not curing the cancer, is it?
No.
No.
And that's why this is a short-term treatment.
Okay.
So over the next day or so, what we're aiming to do is to start treating your symptoms and get you feeling better in yourself.
Right.
In the longer term,
yeah,
after we've reviewed the scans with the specialists and discussed it with them, we need to think about what the best treatment was to be.
Yes.
Now, that would depend, firstly, if it is proven to be cancer.
Right.
As you've said, if it is or it isn't, then the treatments would be different.
Yes.
If it is shown to be a cancer, then the treatment would depend on the type of cancer that it is. Sometimes cancers can be treated with drug therapy. That's what
Right.
they call chemotherapy. Have you heard of any of this before?
Well, obviously, heard of chemotherapy. Christies and people like that do that, don't they? And
Indeed.
what have you? Yes.
Yeah. And if that was to be part of your treatment, then that would be guided by specialists there.
Hmm.
Other treatment options would include X-ray therapy, so that's called radiotherapy, and again, that's something that the cancer specialists at the Christie lead on.
These can all have some quite bad side effects, can't they? I believe. Is that right?
The potential for side effects is there, and there's no getting away from that. What we
Right.
would have to do is work out, firstly, what the best treatment was, because ultimately what we want to do is cure you.
Hmm.
And then what we'd have to do is say, well, this is what we think the best treatment is, but obviously this is a decision not for us to make by ourselves, but for you and family,
Right.
if you wish, to be involved in. So I think
Yeah.
when we've decided what the best treatment is, then it's really for us to say to you, this is what we would advise, these are the benefits potentially, and these are the potential side effects.
Hmm.
And then we can discuss this and you can come to a decision in your own mind as to what you think would be the best for you.
So you're saying actually the final decision really rests with me in a sense.
As much as you want it to, yes.
Right.
It's our job to offer you what is best, offer you options.
Hmm.
We can provide guidance, but any decisions about treatment are yours to make.
I mean, you're saying about this cancer, and you said there were different sorts of cancer and things. I mean, given my age at 28, I mean, where would this come from? You know, I mean, you can sort of imagine it as you get older. You're presumably more liable to catch these things, but you know, early on, I mean, is it hereditary or is it something you catch in a way? I mean, are the children going to be affected? I mean,
Okay, it's a very honest question. It's a very hard question to answer. This isn't something that you've caught in the way that you catch a cough or a cold.
No.
This isn't something that's transmitted person to person. The exact cause of it, I think, is very difficult to explain. There may be an underlying risk just in the way that you're built. We look different. We've got different coloured hair. We've got different coloured eyes.
so
Some of us have a different level of risk for developing cancer.
there could therefore the children could be at some risk then on that argument that you said, because they will obviously have similarities to me, won't they?
That's a fair interpretation of it. Now, this doesn't mean that they are definitely going to get cancer by
No.
any stretch of the imagination.
Mm.
It may mean that they're at increased risk. How old
Yeah.
are you children?
At the moment, well, you know, just young at the moment. There's a 4-year-old and a 6-year-old.
Okay. I mean, I think at this point in time, my main focus is on you and getting you well.
Mm.
I believe if this is a cancer, we've got a very good chance of treating it, and I think that's what we want to focus on right now.
Yes, yes.
I understand your concerns about your family, and I can truly empathise with that, but I think that is something for much further down the line, and our focus right now, as much as we can, should be on you. I understand you're worried about your family,
Yeah.
but what I want to do is deal with the problem we've got right now, and that's getting you better. Come back home with
Can
them.
headaches and things be an early sign, or presumably it has in my case?
It's very difficult to say. There's hundreds of people who will have a headache who will have absolutely
Oh yes,
nothing
yes. I
wrong with
mean,
them.
I've not really thought about headaches
Yeah.
until, you know, in that sort of way until, today, till now.
Yeah. Certainly, I don't think having had the headaches for a week, a month, or anything like that has changed what's happened here.
No.
So what we do is deal with the information that we've got now.
Yeah,
and
yeah.
what I want to do in the first instance, and I'm recapping a little bit, is just to start trying to treat those symptoms. We've obviously got you on some painkillers,
Yes.
but I would like to start these steroid medicines,
Right.
if that's okay today.
Yes,
Try and
yes,
reduce the
whatever you
swelling,
think's
help your
appropriate.
headaches.
Yeah.
And when we have discussed with all of the specialists your scans, then I think what's best is if we meet again, we could then discuss everybody's opinion, and we can start discussing what the best, more long-term treatment option is to get you back home and well.
Yeah. If it wasn't cancer, I mean, you said you think it's likely, but you know, I'm hoping it isn't, obviously, but what else could it be? I mean,
There are genuinely a range of options. Sometimes people can have small infections. Sometimes we can get slightly misleading appearances on a scan, which may just be a variation of normal. Everybody's a bit different.
yeah,
I would stress that what I'd like to do is work on the assumption that we are dealing with a cancer. That is, as you've said, very much the worst case scenario. And I think that's something that we should prepare ourselves for.
yes, yes,
And what I don't want to do is give you the impression that I think that's unlikely.
yeah,
So what the most important thing is in terms of the diagnosis is getting the expert's view. What the most
Right.
important thing in terms of your care is right now is getting you started on some symptom controlling treatment.
yeah. I mean, it's not. I mean, cancer, as I say. I mean, the wife's going to ask this, and I'm thinking it probably. I mean, it's not life-threatening, is it?
I don't know, is the honest
Right.
answer. Many cancers that will affect young people are very treatable.
Right.
However, some may not be. So this is why the expert opinion is the most important next step in
Yeah,
terms
yes,
of
yeah.
Okay. Yeah, interesting. Very, very smooth consultation and a lot of, obstacles and a lot of questioning by the patient. And I think the doctor was able to answer it very smoothly and very effectively. Okay, regarding the prednisolone and the tumor and the headaches. Okay, so yeah, prednisolone is one of the option of treating the vasogenic edema, which is vascular related edema due to the effect of the massive blood supply that is coming to the tumor, okay, but not effective in cytotoxic edema. So cytotoxic edema means if there is bleeding in the brain or there's intracranial hemorrhage with uh, edema, then the prednisolone is not effective, but it's effective only in vasogenic edema. Call for completion of the case because that should be being taken in the recap part of the data gathering of the case when you should suspect what are the red flag, okay, what are the red flag of headaches, which is head crisis been head trauma, especially in the last 3 months, okay, it's part of the post-concussion syndrome, and then you can, especially in elderly or very young children, that they can have delayed subdural hemorrhage, okay, late onset subdural hemorrhage with lucid interval, and then if the headache is worsening with anything that will increase the intra-abdominal, intracranial, or thoracic pressure like cough, valsalva, sneezing, or exercise, or changing the posture to lying from sitting to lying down, because with the lying down, the venous return will decrease to the heart, and then the pressure will increase on the brain. Okay. The other thing, acute closed angle glaucoma, genital arthritis, and then we know why. Um, and if there is neurological symptoms like, cognitive impairment, limb weakness, or change in the personality, especially in the frontal lobe tumors, and then change in the previous character of the headache. So patient with chronic tension headache was becoming a change in the character, or any acute migraine that a change in character, okay, or the patient feeling roasting hot, worse fever, and then headache as well as with neck spasm or neck pain, which can be signs of meningismus or meningitis, and for sure impaired consciousness. And then if there is severe sudden headache that reaches its maximum within 5 minutes, which is thunderclap headache in the subarachnoid hemorrhage, immunocompromised patient because they are more prone for flaring up of HIV, TB, and meningitis and meningoencephalitis. Okay, if the patient have sickness or vomiting without feeling nausea, that's one also of the red flags, or if the patient have previous history of cancer. Okay, all of this are a red flag of headache. The question of today lecture that will guarantee the first doctor who will answer the question will guaranteed 1 hour one-to-one teaching, but in April time will be the 1 hour because in March time I'm fully booked. I can't accommodate what is Cushing triad and what is the significance of Cushing triad. Okay, please, what is Cushing triad? What is the significance of Cushing triad? The first, the first right answer will guarantee you 1 hour one-to-one teaching with me. What are the principles of breaking bad news? When you can use the warning shots, okay, how to show empathy and sympathy without being formulaic and without being, scripted, and then being honest, compassionate, and then acknowledgement and clarifying, okay, some of the patient's phrasing and also patient questioning about what is the situation is. Um, how to use warning shot, how to use poses, and how the poses are very important to absorb the feeling, okay, and let the patient express their feeling, okay, and then the continuity of care by giving them future plan and then future method of communication, because for sure when the patient go home, read more about his condition, he will have more question and more thoughts and more queries, okay, and doubts that need to be explored with the patient, and then to take his hand through his journey to the unknown. Okay, this is a journey to the unknown, and that's scary journey and scary journey, and then and you need to support your patient during this journey. Okay. And these are what I wanted to discuss with you today, doctors. Okay, feel free to contact me at any time at my WhatsApp. We have the Telegram group, the WhatsApp group, as well as the SCA Level Up YouTube channel. I hope today teaching because or yesterday teaching because I did share the teaching for the heart failure, for CKD, and diabetes with CKD lecture, and I think some of you did attend it. I can arrange the whole series, okay, with the details of the whole series of the cardiometabolic syndrome lectures. Okay, if doctor you are happy for that, just please comment in the comment section in the YouTube, or text me in the WhatsApp channel, and I will try to arrange the whole series, which is around 10 lectures, each lecture 1 hour, with the details of the cardiometabolic syndromes that you usually meet on the a clinical practice, with a lot of MCQ questioning and brainstorming during and discussion with the cases. I think it was a very good lecture, but I need to hear from you. Maybe it's you're not interested, maybe it's away from the scope of the exam, although I doubt it, because is the new guy any new guidance is a potential question in the essay exam. I hope you will find my video today helpful, and I hope and I wish you the best in your upcoming exam. And please, at any time, feel free to contact me, and please answer the question, and we'll see who's the lucky one who will take the 1 hour teaching. Um, Thank you very much, doctor. Hope to see you soon, and take care.